Good morning, everybody, and welcome to this morning's webinar. My name is Darren Whelan. I'm an international clinical trainer for the Intra-Acoustics Academy. I would just like to make people aware that today's webinar is being recorded for the purposes of the Intra-Acoustics Academy. Before I get into the presentation itself, let me just give you a little bit of an introduction to myself. I'm new to the Academy, having had 25 years experience as a clinician working predominantly in diagnostic audiology and in particular vestibular assessment and rehabilitation in the National Health Service in the United Kingdom. I spent 10 years being the clinical lead for vestibular assessment, diagnostic audiology, and also vestibular retraining. So I hope to bring some of my clinical experiences to this presentation and to reintroduce some of our understanding and knowledge of the ocular motor testing. The purpose of this presentation is really to come back and look at the relevance of ocular motor testing in the modern balance clinic. As we are presently, most modern balance clinics or dizziness clinics are in the combination of hospital type environments. These can often be either in neurology or ENT or audiology clinics. What we find is within these clinics we have a range of different tests available to us to assess the dizzy patient. The aims of this particular webinar are to describe anatomy and reflexes in eye movements, as these do form the basis of the VNG or vestibular nystagmography assessments that we undertake in clinic. I'd also like to discuss how to perform and measure these oculomotor examinations to successfully understand and quantify eye movements, in particular with the oculomotor exam. And also spend some time describing both the normal and abnormal ocular movements and those clinical importance for the assessment and understanding of dizziness in our patients. So if we start with the oculomotor anatomy and reflexes, these are a combination of pathways that incorporate both the brainstem and central nervous system to both initiate, carry out, and facilitate appropriate eye movements depending on the task that we're trying to undertake. As part of this presentation, we'll look at various elements of this pathway in relation to some of the oculomotor examinations that we undertake. Whilst it's not key to have a very definitive understanding of where these lesions may be present, the understanding of where some of the changes in the eye movements that we see initiate from certainly allows us to have a better understanding of some of the symptoms that our patients may report. And also it's of clinical importance when we then go on and look at eye movements further into the VNG test battery. So if we start with the pathway, so what we have is a motor and premotor system that are generating and initiating smooth pursuit or tracking movements. This is predominantly about keeping a small moving target very closely on the fovea of the retina to keep visual acuity at its best and to detect very small amounts of retinal slip to allow the eye to be repositioned to keep this moving target in focus. These movements are slow and they're voluntary. The Optokinetic system acts in a different manner, but it has a very close relationship with the smooth pursuit tracking system. This idea is to enable us to keep an image on the retina through a sustained head movement. These are movements that are, again, slow but reactive in orientation. The Saccade system is different. This allows us to keep an image of a new object again on the fovea. However, it initiates much faster reactions and faster eye movements to initiate this. Again, we can have a look and recap on the purpose of the patient's ability to look at fast eye movements. And this looks at these back and forth movements in the vertical and horizontal plane. So why should we perform an oculomotor examination? Often the question is raised, well, why are we interested in eye movements when looking at dizzy patients? Well, in my experience in the NHS and in the United Kingdom, over a very large cohort of dizzy patients that had been referred from a primary care setting over a 10-year period, we see the list that I've presented here for you of common diagnoses and conditions that were present in our patients. Very much at the top we have these vestibular conditions that we're familiar with BPPV, vestibular neuronitis, migraine and migraine-associated vertigo. But if we go a little bit further down that list, what we can see are dizziness that is present in a central or vestibular vertigo. So these are patients that are presenting to us with dizziness that then we can see that are not peripheral in orientation, but have elements that could be associated with a central lesion. So that brings us to the question of doing these assessments. Really what we're trying to do is differentiate between these central causes of dizziness and looking at moving away from what are relatively common in our clinic and peripheral and maybe even a fixed lesion to more dangerous central conditions that require a different approach to identify and manage for the patient. So looking at some of the etiologies of the central nervous system, and this list is not fully encompassing, but it gives us an idea of some of the diversity that we can see when we see patients who have dizziness that may be central in orientation. Primarily, the first things we need to think about are ophthalmic conditions, so issues in relation to eye movement and the eyes being able to carry out some of these motor tasks and oculomotor activities. We also have more degenerative conditions that present to us, such as progressive supranuclear palsy. Cerebellar ataxias also can have disruptions within the oculomotor examination. Brainstem infarction, again depending on site of lesion and extent of the infarction, we can start to see more gross changes within the oculomotor exam. Alzheimer's disease and the progressive nature of that condition does often change some of the central nervous system function over time, and dizziness, imbalance, falls, coordination can often be presented into our clinic, and looking at the eye movements gives us some insight of where the changes in the central nervous system may be taking place. Along with other degenerative conditions such as Parkinson's disease, neurological changes such as ischemic attacks, such as transient ischemia attacks and stroke. Demyelinating conditions such as multiple sclerosis can often indicate some nerve conduction changes that may be a palsy in eye movements that again may start to present in a very subtle fashion in the oculomotor exam. And also space-occupying lesions where we have compression and disruption to some of the central nervous system firing and coordination, resulting in dizziness, imbalance, coordination, and often subtle changes in eye movement. So coming back to the oculomotor test battery, initially one would always look at gaze stability, and we can take these piece by piece as we move forward through this presentation, followed by Saccade testing, pursuit and tracking testing, and also we can look at optokinetic testing with full field visual stimuli. Again, the oculomotor function very much sits within the video nystagmography assessment, as this can give us some very non-invasive, well-defined and easily quantifiable eye measurements to allow us to further identify any changes that we may see present. With video nystagmography, it's worth noting that using the video goggle to track and monitor eye movement in high resolution does allow us to quantify those measurements, and often then allows us to further look in detail to take into account attention and head movement and medication, and excluding those so that what we are left with in our measurements are these changes that may be part of a central nervous system condition. So if we can start with gaze stability testing. With gaze stability, what we're trying to achieve is looking at both primary left and right gaze. Here, what we want to see is whether or not we have any changes in the patient's ability to maintain gaze, both with the generation of other eye, without the generation of other eye movements. We can check this both with fixation and without fixation, and this becomes important if we then do see some instability within the gaze assessment. The most common instability one would see is something being driven through nystagmus. So nystagmus being present in any of the three conditions will have an effect on other eye recordings further in our VNG assessment. If that nystagmus is present with fixation, this is going to affect our Saccade testing and our smooth pursuit testing, and also will have an influence on our optokinetic testing. If that nystagmus is present with fixation removed, then again this could be present both in positioning testing with VNG goggle and also, more importantly, within a chloric assessment with fixation removed. So quantifying gaze stability as a primary examination before conducting other oculomotor examinations does have some very sound clinical utility. What we can see here is the eye movement relative to the target. In this case, the eye is moved to the right, and we've tracked that with the eye moving to the same position and holding that position. Here we can see an ideal example where we don't have any eye movement whatsoever, and we don't have any ocular movement or flutter. During this assessment, we often can take the time to check that the patient is just eliciting an eye movement and not a head movement, as it's very tempting for a patient to, when looking right or left, slightly move their head. Now that will have an effect in terms of where the eye position is, and also they then may make corrective eye movements to reposition their eye. This can again be seen in the trace, and a reinstruction can be offered and some mental alerting tasking if needed to keep them in the correct position for the eye examination. So here we can see some examples of nystagmus that has been elicited in different eye positions. And again, as we move forward through our oculomotor examination and also then further into the VNG, we can take these into consideration when looking at any other nystagmus or eye movements that are present. So, gaze stability. So this is the examination of the patient's ability to maintain steady gaze with and without fixation. And as we have said, the most common manifestation of that gaze instability is nystagmus. If we just take a quick look at a video here, we can just see some very quick eye movements that allow us to see some video nystagmography being undertaken. Our next test moving into the oculomotor examination is Saccade testing. And what we can see here with Saccade testing is we have more random eye movements being generated that are quick and can move both horizontally and vertically. And we can track the eyes moving for each of these random steps. To quantify Saccade testing, we need to carry out approximately 20 saccades in each direction to fully utilize the pattern or changes that may be present. These measurements can be indicated as follows. What we can see here is a step change where the eyes have moved from a left position across primary into the right position, and they track the target and follow the target back once again. Now within this test we've got some different parameters that we can look at that allow us to quantify some of the abnormalities. So I'd like you to have a little look at our first abnormality here. What we have is an eye movement, and what we're measuring is a latency of eye movement. So the time that it takes for the eye to move after the target has initiated the eye movement. Typically what we would see are eye movements around about 100 to 120 milliseconds following the target movement. Any delay in this movement of greater than 200 milliseconds, if it is a consistent pattern and follows through the saccades, we can look at whether that eye movement is delayed both unilaterally, either to the right or to the left, or up or down for vertical saccades, or whether it's bidirectional and that it's present in either the horizontal or the vertical plane. Abnormalities within the latency of movement are often described within the central nervous system structures as being frontal or frontoparietal cortex, or even within the basal ganglia. We can come back to some of these abnormalities further into the presentation. Our next parameter to look at within the Saccade test is velocity. So how fast does the eye move after being initiated following the target? Again, we can look at normal data, both for age, gender, and we can have a look at whether a delay in this eye movement, again, is present either in a unilateral or bilateral directions, again, horizontal or vertical. And delays within velocity give us some indication within the central nervous system of looking at structures such as the supranuclear complex, the brainstem, again basal ganglia, and are often associated with more neurodegenerative diseases such as Parkinson's or Huntington's or progressive supranuclear palsy, and even spinal cerebellar degeneration. Our other parameter to look at within a Saccade test is accuracy. Now this is calculated as the percentage of distance that the eye is often moved following the first target movement. If the eye moves to the same distance as the target has moved, then this is 100% of movement. But we can then start to quantify that movement both as a percentage and its nature. So we may have a movement that doesn't fully reach the same point as the target. That we would describe as hypermetria. And again, these could be lesions that are affecting the cerebellar flocculus or the dorsal vermis. Or we may have a movement that's actually exceeded the target movement, and then a correction has been placed back on the target. And again, these would be more consistent with lesions within the cerebellum. An example of an impairment to the Saccade test, we can look at internuclear ophthalmology, myoplegia, and that can have palsies both in a unilateral or bilateral direction, where the eye adducts inappropriately, creating either doubling of vision in the horizontal plane and dizziness and unsteadiness if the patient is stood. We've said before, is more of a voluntary, slow reactive test. And what we're doing here is we're looking at the patient's ability to keep a small, slow-moving object in the fovea, identifying the retinal slip and making a correction appropriately. Now this can be tested at different speeds, either with fixed velocity or increasing velocity, to identify any impairment that may be present. So what we can see here is we have our target that has moved in a very sinusoidal fashion, and the eye movement is tracking and moving both at the same speed and distance as the target. We can look at different parameters within the smooth pursuit, so we can look at gain as being a measure of the eye movement versus the target movement. We can look at whether the movement is within phase of the target movement, and we can also look at any asymmetry. As with our example with intranuclear ophthalmoplegia, we could have an asymmetric palsy, therefore a direction in to the left or to the right may elicit a abnormal eye movement that would be identifiable through our smooth pursuit examination. Here is an example of a bilateral symmetric abnormality. So what we can see is we've got correction being applied both to the right and to the left directions to keep the eye tracking with the trace. Lesions that are bilateral identify within the central nervous system often diffuse cortical changes, again basal ganglia changes, and cerebellar disease. We do have to be mindful of medication, and I'll talk about that a little bit further into our presentation, and also age. Pursuit is very sensitive to age related changes, and therefore we need to consider this as we look at older populations. A unilateral change, either in the right or left direction, identifies slightly different areas within the central nervous system as being involved in that pathway. So we may be now thinking more of a focal lesion or an ipsilateral cerebellar hemisphere, such as an ischemic event, or within the brainstem or the parietal or occipital lobes. What we have here is an example of an optokinetic stimulation. So what we could see in that example is a full field, with the patient sat in front of it, a full field stimulation that initiates a checkerboard or striped pattern to induce a corrective eye movement that very much looks like nystagmus. So we're generating a nystagmic eye movement that we can measure both going to the right and to the left to assess whether or not the patient is able to initiate those eye movements appropriately and symmetrically. Here is an example of some of those recordings that we can see within our software, and this allows us to quantify the slow phase velocity of those eye movements and establish whether we have equal gain. Does the eye move to the correct degree of movement, both right and left? And we can look at this at different velocities. So we could look at 20 degrees movement or 40 degrees per second of movement, both in the right and left directions. We can also look at the slow phase velocity of that nystagmus and calculate a symmetric or symmetry value to see whether we have any lesions or changes that are predominantly moving either to the left direction or to the right direction. So if we again look at the Optokinetic, the purpose of that is the pursuit mechanism, as we've said, looks at stabilizing these small targets within a visual field, whereas the Optokinetic is to stabilize the entire visual field onto the retina. So whilst one is slow and voluntary, the other is a reflexive response. At this point, it's worth mentioning that the Optokinetic, out of the oculomotor examinations, has the least specificity in relation to identifying a central nervous system pathology. However, as an additional supportive test within the oculomotor examination, you can see where it would show changes potentially both between the pursuit and the Optokinetic to see whether we've got consistent findings within our oculomotor examination. So what I'd like to do now is come and look at the oculomotor test battery as an overview. We've spoken about gaze stability testing and the importance of gaze stability testing in relation to looking at any nystagmus or instability within gaze testing that may influence our oculomotor exam, or even importantly further into the V&G examination when we look at eye movements with fixation being removed. So to recap, this is to examine that patient's ability to maintain steady gaze in different conditions with and without fixation. We've considered Saccade testing. The purpose, obviously, with Saccade testing is to examine the ability to make fast eye movements in that horizontal and vertical plane. We've considered smooth pursuit testing. And again, we've addressed that in terms of looking at these slow, foveal tracking eye movements to identify that very slight retinal slip of 1 to 2 degrees per second and repositioning the eye into the correct area of the retina to keep visual acuity present. And we've looked at Optokinetic, and we've identified that that requires a full field stimulation to initiate this reflexive response in relation to these changes. Now, we've discussed some of the abnormalities within the oculomotor examination, but now let's just take a moment to recap some of these abnormalities. So within Saccade testing, what we said we would look at is the latency, accuracy and velocity of these eye movements. And we would look at these individual components and examine the abnormalities that may be generated, and looking for repeatable patterns that may then identify central nervous system changes or conditions. We've considered smooth pursuit, and within that we've looked at elements of gain, so the eye movement relative to the target movement, the phase of that movement of the eye tracking the target, and also any asymmetry that may be present within that eye movement, whether these changes are bilateral in nature or unilateral, as each change can indicate a slightly separate location within the central nervous system of where the abnormality may be being generated. And we've looked at Optokinetic, and again, whilst normal values for optokinetic testing are not well defined, what we are able to do is look at the gain and the slow phase velocity of the nystagmus that we generate, and we can use a qualitative assessment of these findings to see whether the examination of that nystagmus intensity is either reduced unilaterally, bilaterally, or whether there is a velocity change. We've also said that we can measure the optokinetic at 20 degrees per second and also 40 degrees per second, because sometimes abnormalities may vary with velocity, with some of the higher velocities eliciting an abnormality that's not present at slower speed. And once again, we've said that whilst this is not a diagnostic test in terms of location within the central nervous system, it's a complementary test in terms of supporting changes that we may then see in smooth pursuit testing or Saccade testing. So to summarise within our site of lesion, within Saccade testing, we've said that abnormalities are consistent with medial, longitudinal, fasciculus changes, the lateral medulla and frontal or frontal parietal cortex, or within the basal ganglion or cerebellum. Smooth pursuit abnormalities have been identified within the diffuse cortical lesions, basal ganglia, or cerebellar disease. We also can have focal lesions, brainstem, and again, parietal, occipital, regional changes. So in conclusion, the oculomotor testing is a valuable examination to identify any subtle central changes before some of these conditions have progressed. This allows us to identify more dangerous causes of dizziness imbalance within our clinic that are not peripheral in nature and require different management and investigative modalities to address the patient's concerns. We've also looked at the identification of these oculomotor abnormalities as allowing us to do more accurate interpretation of other eye movement recordings in the VNG test battery. The VNG test battery, as we know, very much relies on us establishing peripheral function and positioning changing symptoms in relation to eye movements. So an impairment within the oculomotor or gaze stability can have influences in terms of the VNG recordings that we may then use further in the test battery. This is very important when we're trying to localize site of lesion, and also in terms of then initiating management and treatment options for these patients. In summary, the oculomotor examination has good clinical utility, and the validity of its use within the test battery is very much consistent as a diagnostic tool to separate central causes of vestibular or dizziness being present from those that are peripheral in our test examinations. So thank you for joining me for this webinar. My contact details are as follows, and if you have any further questions or follow-up, please contact me on my email. And I'd also like to draw you attention towards our other Academy materials on the Intraacoustics website to further engage you with auditory and vestibular imbalance materials and our hearing aid solutions. Thank you very much.